Welcome back, everyone. In the last session, we heard from Dr. Ashamala a very powerful message, and that message was that a colostomy is better than any degree of incontinence. And I really just wanted to bring that message forward as we move into this next session, where we are joined by Mary and Engel, who will present today on ostomy care and management. So Mary, who is an NSWOC since 2001, has worked in community and acute care and is an academic advisor for the ostomy cohort with the NWOCEP. She has affiliations with NSWOC, the Registered Nurses Association of Ontario, and Ostomy Canada, and has spent many years leading the ostomy support group in her region. She initiated the part-time NSWOC position at Cambridge Memorial Hospital and expanded it to full-time upon her retirement in 2019. Her passions are lymphedema and supporting ostomy knowledge within the community. So a very warm welcome to you, Mary, and I will now pass it over to you to get us started here.
Thank you very much. Now, I'm not sure if you can see the screen
Not quite yet.
because it's I wonder if you can help me out there.
Sure, yeah. So just
maybe this one?
Share
Is it
screen
that
at the
one?
bottom. No, we can't see anything just yet, so I'm not sure if you need to go
sorry.
back to share screen at the bottom.
Can you see that now?
We can see that now, and you'll just need to swap your display settings because we're seeing the presenter view. So at the top in the middle there, it says display settings. Along your top bar.
Yes.
Yep. And then just swap to presenter.
Perfect. Okay.
Didn't quite swap yet.
Oh.
Maybe try one more time with the swapping display settings.
Well, where is display setting presenter view? That's what it's showing me. Are you able to do it from your end? Or should I go to the... I'm sorry about this, guys.
No, that's okay. Technical difficulties are part of the world of Zoom, no problem. Why don't you just try stopping sharing and we can get into it perhaps a different way. And Himanshi, in the background, if you can let me know if we have these slides and they can be shared. I think Mary, the problem is perhaps because you've got two screens.
Oh, should I? What do I need to do?
Why don't you try just bringing it up again and we'll try sharing through a different way.
Okay.
My colleague Himanshi's working on it diligently in the background here as well. It looks like Himanshi's actually pulling them up, Mary, and she can share them on your behalf if that would be easier for you.
Okay. No, I just have to see it though.
So just bear with us, folks, as we manage some technical difficulties here. Again, always the joys of virtual presentations, but we will be right to it shortly.
Oh, there we go.
Okay.
Okay.
There we go.
Mary?
I can, yes.
Excellent. There we go, Mary. There we go. And welcome. Welcome.
Okay, and can I move them forward, or is that you doing that?
That is done on our end, so you just let us know when you're ready to advance, and we'll look
okay. Well, I'm ready to advance. Okay, so what I wanted to talk about, my presentation is not particularly couching and just looking after the stoma itself, but I'm talking about the ostomy management in total. So we're going to just do a little review of the digestive system in relation to colorectal cancer, and then talk about some types of ostomies and surgeries related to this. What you're expecting in terms of output, and what we're going to talk about in terms of the pouching systems themselves. So those of you who are knowledgeable about digestion and how this works, we are basically producing mucus from one end to the other, and that helps our peristalsis and things move through our system. So what happens is we chew our foods and then we get it down into the stomach, where the stomach acids break things down. But the main thing I wanted to talk to you about in terms of the stomach is that it produces this intrinsic factor. Now, what slide are you on? Sorry. Are you on digestive system or not? I want to know where okay, perfect. And we know that the small intestine itself is about 5 to 8 meters long. It's a very long system. So in there you have many layers, but in the top layer that has the mucus within it, it has these villi, which are like little projections that help to absorb foods digested particles and fluids and mucus and whatnot through the system. And when we lose our colon, these villi become longer, and they contain many parts, the lymph system, the blood system, whatever. But the idea is, as they elongate, they adapt to being able to increase their fluid intake so that they absorb more of that. And that's what we call adaptation. So as we go along into the colon, as we go along into the colon, we have more fluid absorption, but most of the nutrient absorption is done in the small intestine. And then as we get down into the cecum and rectum, basically it's just waste product. So if you had in the last section of the small intestine, which is called the ileum, in the last, say, 25 to 30 centimeters, that's where the intrinsic factor becomes important, because it helps the body absorb the vitamin B12 and the bile salts. So remember that when we're talking about ileostomies and the surgeries that go along with that. And next slide, please. So when we get down into the rectum, it's the part that holds the waste products. And that's important because we need something that will act as a holding tank for us before we have to evacuate. And the anal sphincters work the internal anal sphincter works it's always closed, in other words, unless you have that push from the anus, or that tells it you have pressure in behind it and you want to open it. And then on the other hand, the external anal sphincter is generally a little bit open, unless you're squeezing your bum tight together. So what I want you to remember here is just above this anal sphincter, we have it's very sensitive, and this is where we do the sampling of, well, for instance, if you think you need to pass gas, this little area here can help you decide, is that gas, is that fluid, is that poop, and what do we have to do about it? Can we just pass it as we're walking along, or do we need to get to the toilet? So that's what I want you to remember for there. Next slide, please. So I know Dr. Ashmala talked about surgeries, but my focus here is more on what happens. And here we see in that abdominal perineal resection, we have the removal of that anus. And so you have a perineal incision there, and it needs to be sewn closed to heal. And then the healthy end of the stoma is brought out to the surface. Healthy end of the colon is brought out to the surface to make a stoma. Next. And in that low anterior resection he talked about, well, these are generally cancers that are in that middle to higher part of the rectum. And so that affected part is removed. And then the remaining colon and the remaining rectum, or the anal sphincter area, is attached together again. Now, when this is done, they often will make a temporary ileostomy, which is a loop ileostomy. I know in the picture it shows an end, but there you go. There are issues with having that loop ileostomy, and we'll go into that a little bit later. But also, I want you to think you don't have a rectum anymore. So then this is where whoever is the Lars expert out there understands the complications that may come afterward. Next. So I mentioned total and restorative proctocolectomy here only because sometimes what happens is the Crohn's or colitis maybe will have issues in the rectal anal area where there's no hope of recovery, and they have been long standing, and then they can become cancerous. So the colon, the whole colon for ulcerative colitis, because it's only in the colon, is removed. But it's a little more difficult with Crohn's disease because we never know where that's going to end up. However, with ulcerative colitis, they can make an alternate means of evacuation by making this J pouch, and that's made of probably the last 20 to 45 centimeters of the ileum made into a pouch and sewn to that above those anal sphincters. And that becomes your pseudo-rectum. So while that is healing, you have a loop ileostomy as well. Okay, and for the total proctocolectomy, you will also have a perineal incision as well. That's okay. Next. In a Hartmann's procedure, it's a very limited amount of bowel that's removed, and it's wherever that tumor or obstruction or whatever it happened to be is removed, and the stump, that rectal stump, remains, and it's stapled off. And so with these people, it's an end colostomy that is generally really low down in the descending colon. So you have more or less normalized output. And this can be reversed, although many people are not reversed. Next. So let's talk a little bit about stoma types. In terms of these, we have an end stoma, which is basically the bowel brought up to the surface, turned over on itself, and sewn to the skin. And these are generally permanent. With a loop stoma, you have two openings because a loop of the bowel is brought up to the surface, and it's partially open so that you have the end that has the output from it, and the other end that's directly attached to where the anastomosis is, and it only produces mucus. And so we call that a mucus fistula, or a defunctioning end. And because it's a loop, sometimes they put a rod in underneath in the initial stages so that you understand that it won't fall back into the belly. This is not always used anymore because the surgeons don't make such big incisions around the stoma. Next. So we have ileostomies and colostomies. Well, we understand now that an ileostomy is part of the small bowel. It's the end of the small bowel. And initially, in the first day or up to 3, there may not be any output. But after that, because adaptation has not occurred, it may be as much as 1,000 to 1,500 mils. And after your body adapts to this, then it can go down to about 800 to 1,200 per 24 hours. In the beginning, it's very liquidy, and then afterward, it becomes more of a mushy consistency. But certainly, because we haven't absorbed all those enzymes, there can be more enzymes related there. What else might be affecting the output of the ileostomy would be if you have chemo or radiation. And what happens there is that you can get more irritation to your skin because this is corrosive and is more liquid output. So for a colostomy, well, that can be anywhere along the colon, and the farther down the colon, the more solid the stool. And in general, it works out to about 600 to 800 mils in a day. And if it is far enough down as a descending colostomy, you will find that the output becomes more or less what your usual routine used to be, 1 to 2 bowel movements a day. And because we are now just waste products, it becomes more odorous and gassy. So what are some complications that can arise from an ileostomy? Well, because it's higher in the bowel and we don't have the absorption capability, they can become dehydrated and have some electrolyte imbalance. And this can become quite an issue in terms of management and because you're constantly trying to keep up with the flow in your pouch, and also because it can cause acute renal failure. So what else can happen? There can be blockage. Depending on what you're eating, if you're not chewing your foods well enough in the beginning, in the first 6 to 8 weeks, you're fairly limited to a soluble fiber diet. And if you're not chewing your foods well enough and being able to absorb those, then they can block the system, and then you might need to have what they call an ileostomy lavage, which just means it's sort of like an enema through the ileostomy. But what else can happen is we can get peristomal irritation. Next, we'll go into those. So what can we do in terms of dietary? Well, we had a really good overview of dietary considerations from the nutritionist previously, but certainly with your ileostomy, you have to maintain that fluid balance. Now, how can we do that? Hypertonic fluids pull water into the bowel, so it makes it rush out faster. And what are these? Well, fruit juices, sweet teas, ice cream, sherbet, sweet gelatin, those kind of things. Sometimes even if you are prone this way, the liquid nutritional supplements can do this because of the sugar content. Not always, though. But what else? Hypotonic fluids. And these are fluids that pull sodium into the bowel, and thus it pulls the water with it. So what happens with these? You also have an increase in your output. And that would be things like water, tea, coffee, diet drinks, alcohol. You can have a small amount of these, but certainly, that isn't your mainstay. And what do people do to try and maintain these electrolytes? Well, they want to have something that has sodium or potassium in it. So they would have broth or vegetable juice, maybe the low sugar sports drinks, any of the electrolyte solutions. You can make your own St. Mark's solution. There's always a recipe online to help you with that. And you can make it into frozen popsicles. Yogurt, applesauce, pudding, those kind of things. But soluble fiber is the key to help with in your diet during this first section of healing. And this means that we can't have skins and seeds and nuts because those can, again, start to clog up the system. If you want to have cashews, you have to blend them into a butter, and then they're able to be absorbed, for instance. Try and have frequent meals, 4 to 6 meals a day, because that helps, gives you time for the small bowel to digest foods a little slower. And make sure you chew your food. The CRAN resources are very good talking to us about foods to have after surgery. And the only changes I'd make is to start out with ground meat instead of eating, like the whole chicken or whatever it happens to be. And make sure your fish is flaky. And if you're going to have beans, make them blended like hummus or something of that sort. None of the crucifers, unless you're going to make them into a smoothie and make them really smooth. And then it's interesting, but mushrooms can swell and create blockages in your system. Next. So what about colostomies? Well, when it comes to colostomies, I'm looking more at the descending colostomy. That's generally where we see them. And here, constipation is one of the big factors. When we talk about pancaking of stool, that's still constipated stool. It just means that the stool is dry enough to suck the moisture from the pouch to make it a vacuum, and then the stool exits underneath the flange, so it makes like a pancake on the skin. And this becomes difficult for people because they have a need to change their flange more often. In order to help with that, well, certainly make sure that you can put some lubricant into the pouch. Make sure you don't have a filter on the pouch or cover the filter so that the air, if any gas, will fill up the pouch. It lets it stay puffed so that the stool can go into the pouch. And then we want to avoid constipation, and we'll get into the dietary considerations there. And again, because of gas, that's okay. Because of gas, because we're so far along in the bowel, the gas becomes more of an issue. Okay, so to help ensure that you're hydrating yourself enough, but these people need to increase their fiber. And I just want to mention psyllium here. People are often using things like Metamucil or whatnot to help bulk up their system so that it flows a little better. When you're using psyllium, this is meant for people with colons. It's not meant for people with ileostomies, because what it does, it binds the minerals and prevents the absorption. And so it might exacerbate your electrolyte problems if you have an ileostomy. Yes, it will thicken the output. And yes, you can use it if that's what you need to use it for in order to help you with a change or your appliance or something like that. But no, don't use it ongoing because it doesn't hydrate you. It takes, because the water is now bound to the fiber and it's excreted in the stool. So, what else? Yeah, again, the CRAN resources have good nutrition information on that. Next. So let's look at what we want to know about our pouching systems. Well, certainly wear time is a concern. Most of the time, what I say to people who have ostomies is that for an ileostomy, if you get 3 or 4 days of wear time, that's perfect. Don't expect it to be lasting a week just because it says it can. Because if you have very liquid output, your flange will be washed away more quickly. So you want to make sure that you don't allow your skin to get irritated from trying to increase the wear time too long. For people with colostomies, 5, maybe 7 days would be considered good, but please don't try and extend it to longer than that. Your skin needs to breathe and it needs a little air time and cleansing for it to maintain itself. And then comfort. Well, there are a variety of issues in terms of comfort, and that we'll discuss some of those coming up. Then when you're choosing your system, you have to think about the height of the stoma and where the os is. Because if the os is at skin level, then you might need something that has more of a convexity. And we'll go into convexity a little bit, but to be able to push the os up off of the surface. If the stoma is flush to the skin, then you might also need a convexity. If the stoma is sitting nice and high, meaning it's anywhere from 2 to 3 centimeters high, then that's perfect. And if it's within a dip or ridges, then we have to think about what kind of a flange we're going to use for that. But certainly the best thing is to make sure that whenever you're fitting your stoma, your flange, it's going to fit within a millimeter of the edge of the stoma. You want to maintain that skin integrity around the stoma. And we know in the beginning the stoma is swollen and enlarged, and when you come home from hospital, you're given a certain size. And if you continue cutting to that size, it will become too big and you'll get irritation around your stoma. So within about, we'll say 3 to 4 weeks, it will be changed. You move backwards, I think. Next. Okay. So for the flange properties, they're made of either hydrocolloids or silicone blends. So the hydrocolloids will be, they'll absorb moisture from the skin. So some people will say when they take their flange off, or even when they don't take their flange off, they feel itchy. And that may be because they might have dry skin underneath, even if the skin looks intact. Hydrocolloids do enhance the adhesion, which means the stickability to the skin. It doesn't mean they're adhesive, it's just the adhesion. The erosion rate is influenced, though, by the output from the stoma. So you can have a hydrocolloid that when you remove the flange, or you see that it's washed away around the inner edge, and that's because the output has been liquid enough to do that. And some of them have some skin healing properties like aloe or manuka or ceramide. So for the silicone, they're hydrophobic, which means that they don't, they don't like water. In other words, they don't take water from the skin. They're permeable to gas. They're generally hypoallergenic, and they have a lower surface tension. So if these suit your bodies, and not everybody can use silicone because it doesn't want to stick for them, but if these suit your body, they're probably the easiest for on your skin. Next. So the characteristics we have in terms of a flange are regular or standard wear and extended wear. And this means that how long they're expected to last in terms of the ability of the flange to wear with the moisture being produced from the stoma. And then we can have ones that don't have tape and ones that do have tape. We can certainly have pre-cut ones if you have a nice round stoma or one that's almost round that can fit into something that's pre-cut. And that makes it easy for people that have difficulty with cutting with their dexterity or with their vision. We have cut to fit for people that have irregular stomas. And then we have the moldable type. And moldable flanges are ones that can be pulled back to the shape of your stoma. And then what happens is it sort of rests back against the stoma. So if you have a stoma that isn't protruding very much, then what happens is that resting edge tends to cover the stoma, and that creates leaking underneath. If you have a nicely protruding stoma, it works very well. And these I generally would use on a colostomy as opposed to a more liquid output ostomy. And then we have something called a floating flange, which just means you can get your fingers in underneath to couple the edges together to the pouch. And speaking of, coupling systems are either snaps, they snap together, or they click together like Tupperware, or they stick together like adhesive one to the next. Okay. So let's look a little bit about convexity, because not all convexity is the same. When we check our convexity, we want to know what the depth of the convexity is. We want to know what the slope is, for instance, and we want to know how compressible it is. Is it able to move with your body when you're wearing it? And where is the tension around the stoma? Is it farther out or is it close to the stoma? So if you look at these bottom pictures, you'll see two varieties. We see a stoma that is fairly flush to the skin, and the skin is fairly flat, and we have a convexity that is fairly snug around that stoma. And when we put that convexity on, it helps the stoma to protrude. In the second picture farther to the right, we see a stoma that has a fairly wide dip around it. It is protruding some, but when we want to put the convexity on this person, we want to include this wide dip. So we have the tension area wider on the skin so that it fits nicely, and the skin around the stoma is nice and flush as well. We also have flat flanges, which if you have a fairly well protruding stoma and a fairly flat surface to pouch on, you can certainly use those, and that makes it easier. And those that have an out protruding belly, or so those with hernias can use a concave flange. They're made especially for that. All right, next. So now we get into pouches, and pouches can be 1 or 2 pieces, and many, many styles of these. They're flexible, they can fit into contours, and 1 pieces are generally what people want if they want a low profile system, something that isn't going to show below their clothes. And again, there's no chance of separating because it's all 1 piece. So the problems, however, is it can't be burped. The air can't be burped out of it. And burping a flange, it means that you can, if you have a 2-piece, you can open the edge of where it's coupled together and then just press gently on the pouch, and the air can come out, and then you can snap it back together. And that's what we call burping. It means that you don't have to let the air out you don't have to go to the bathroom to let the air out. Again, when you have a 1-piece system, you can't change the position once it's applied. If you take it off to put it in a different position, it won't stick. And these people may have a soft convexity built into their system, but it may not offer the support that you want if you have very loose skin. So for a 2-piece system, you have more of a rigidity that it can provide that support. And you can change the way the pouch lies. Say, for instance, you want to wear something called a stealth belt, that you can turn the pouch on its side and hide it within this belt. Because it's 2 pieces, it's going to be more expensive. And you have to have some dexterity to be able to close this system. And so these, even though there are some 2 pieces that have what they call soft convexity, it is still less flexible. So, as I said, they snap together, click together, or they have adhesive to slap it together. And for all of them, you need to have a clean surface to work on. If you are removing a pouch and replacing it with another one, you have to make sure that the area you're going to put it together in is clean, and otherwise it may not close properly, or there will be an odor to it. And people with who are undergoing chemotherapy may have neuropathy in their hands, and this might become an issue for them to be able to close the system. So they might need something that's a little easier. And those with visual difficulties, well, certainly we can suggest, adequate lighting, a mirror in front, but still they'll need to be able to see where they're going for this. Okay. Next. And then they can be closed end or drainable. Well, the closed end, they're disposable generally. And you know what? You can use liners with these. And if you use liners, you can take out the liner that's full of the output and put it back in, and then still use that same disposable pouch. And liners are generally fairly inexpensive. They're made of material, like our compost bags that are recyclable. They're made of material like that, and they fit into the pouch, and then you have to just lay the edge over the coupling system and couple them together to make sure that you're getting the output in fully into that pouch. And you can get 100 of these for about $30, $35, which is pretty, reasonable if that's what you're going to use. These closed end pouches come in small or regular length, or even stoma caps if that's what you're wanting. And they come with or without filters, and they're generally opaque. But they're used for people with colostomies, or generally, and sometimes we use them for a small output fistulas as well. The drainable pouches, however, are open to the bottom. They have either a Velcro type closure, a clamp, a tap or a spout. And they come in various lengths as well. If you have high output, they can be very long, and these generally have a tap at the bottom so that you can empty it fairly easy. However, if you have output that is thicker, it makes it more difficult to get through this tap. So you probably will need a regular Velcro type closure or a clamp closure. And they come in pediatric size, again, if that's what we're using for, say, a fistula. They can come in either clear, opaque, transparent, and they can come with filters or not. And as I said, liquid or mushy output, and some can be attached to a leg or a bedside bag. So when we're looking at accessories, I always say less is more, because the more you put on your skin, the harder it is to know what is causing your problem. So when you're cleaning, a nice soft washcloth or a J cloth or a soft paper towel is the easiest thing, just plain water. Some conditions, you might need an antibacterial cleansing solution, like, for instance, folliculitis, or maybe even pyoderma, or some maybe candida as well. But we want to make sure the skin is clean afterwards. Please don't use baby wipes. They're not recommended for around your stoma, and they have many things in them, like surfactants, which are meant to clean an area. They have preservatives. They have something to change the pH in the system. And they might have perfumes or lotions or potions in them. So you won't get a clean skin surface to be able to add your pouch or your flange, sorry, to the skin and make it stick. And if you're using remover wipes or spray, some people want to use this if they have irritated skin and they don't want to be pulling on the skin, and that's fine. Or if you have trouble getting your flanges off, and you tend to pull too hard and you tear the skin, then you want to be able to use those adhesive removers, and they must be alcohol-free removers, please, to be able to ease those off and cleanse the skin after. And then last, or not last, but finally we get to stoma powder, and that's the one everyone seems to have. And remember, it's pectin based, so use it sparingly, because it will build up on the skin and then the flange will not stick. And when you come out of hospital, if you have what they call a mucocutaneous separation, this means that some of the edge of the stoma has not the sewing has come apart. There is a wound there called a separation. We often will just fill that with powder, because powder absorbs, and then we can clean it out when we change the system the next time. If you're not using one of those, the regular stoma powder, we do have a silver powder that helps, and we do have an antifungal powder that also would help, depending on the situation with your skin. But always apply these very scantly, and then wipe away any excess, so that you can make sure your skin will stick, your flange will stick afterwards. And then liquid skin barriers, they come in variety: wipes, sprays, wands. Remember to get ones with no alcohol. And you might need these to seal the powder, and that we know is called crusting, but it's not generally used like that anymore. We generally lay the flange or the ring on top of the powder itself. And make sure you discontinue this when it's healed, and don't use it routinely. It doesn't help the flange stick, It just puts a coating on your skin. And in fact, if you use some of the long-wearing barriers and use this as a skin barrier, the flange will not stay on your skin.
Mary, I'm just going to jump in with a time notice.
Yep,
We are just
yep.
wrapping up. We do want to make sure we've got lots of time for our cancer coaches to have a
Okay,
chat with you after the session. I know there's just a few slides left. But
okay,
if we can just kind of run through kind of the last summary on
sure.
the last couple slides. Thank
Okay,
you so
sure.
much.
Yep. So what we use rings for is to either help make a convexity or to add more absorption ability. So they are made generally of hydrocolloid. We do have some in silicone now, but generally they're hydrocolloid and they're flexible enough that you can stretch them to fit around your stoma. And they come in various sizes. Paste comes in a tube or a strip. And it's probably more economical because you can fit it easily into creases, but be careful with the alcohol content for these. Next, thanks. Odor eliminators, well, ask the person why they want these because they can become very costly. If you're going to use something, spray the room spray and make sure it's an odor eliminator, not a deodorizer, to into the toilet, and it will reduce the smell when the pouch is emptied. And as I talked about liners before, just be careful in a septic system with these because they can clog the system. And then we have belts, the regular ostomy belts, and then different concealment and security products like a stealth belt or a belly band or stoma guards can be protective to your system. And they can you can also use a pouch cover, which is just usually a cotton version of a covering for the pouch, and it keeps the pouch from sticking to the skin. Okay.
Well, thank you so much, Mary. I'm just going to bring up my slide here for the break. So,
Mm-hmm.
ostomy management is such an important topic for to improve and maintain quality of life, and we're so grateful to you for sharing some insights with us on this topic today. What we'll do now is our coaches and Mary will go backstage and have the opportunity to have that interactive discussion. I will highlight Cran does have a My Ostomy coach, our very own Cheryl, through our Colorectal Cancer Coach program. If you are facing the prospect of an ostomy, whether it be an ileostomy or a colostomy, or if you already have an ostomy and you'd like to connect with our cancer coach, she would be more than happy to help you out, to assist you, guide you, and provide you with some evidence-based information. So coaches and Mary, go ahead and go backstage. And for our live audience, our next session begins at 1:45. We will be back with Dr. Mary Jane Esplin speaking about coping skills for the colorectal cancer journey. Just a kind reminder to please go back to your email and use that afternoon link to join us after the break. Enjoy your lunch and we will see you soon. Thank you.